This is Mohammed Sami Al-Hamadi presenting a video on the microsurgical management of cerebral arteriovenous malformations by Mohammed Sami Al-Hamadi, Florian Roser, and Roberto Hiros. An arteriovenous malformation is an abnormal collection of blood vessels consisting of a direct fistulous connection between arteries and veins without a normal intervening capillary bed or functional neural tissue. Since the discouraging early surgical experience of Cushing and his contemporaries, we have made tremendous advances in our understanding of the pathogenesis, clinical presentation, and natural history of cerebral AVMs. Furthermore, major developments have been made in microsurgical, endovascular, and neurosurgical treatment of these lesions. In this chapter, we will review the epidemiology, clinical features, and natural history of cerebral AVMs and discuss the indications and outcomes of the various treatment modalities. We will make some comments on the surgical technique and nuances of AVM resection in particular locations. Cerebrovascular malformation is a general term encompassing several distinct entities, each with a different microscopic structure, physiology, and clinical behavior. The most widely accepted classification of cerebral vascular malformations was that proposed by McCormick. In this scheme, vascular malformations are divided based on the nature of the component vessels and composition of the intervening neural tissue into four major types: arteriovenous malformations, venous malformations, cavernous malformations, and capillary telangiectasias. The usefulness of this classification system is demonstrated by the fact that each type of lesion has distinct clinical and radiological features. In this chapter, we will address parenchymal AVMs, that is, lesions within the brain substance consisting of direct fistulous connections between arteries and veins without a normal intervening capillary bed or functional neural tissue. Intracranial AVMs are uncommon lesions. Their incidence and prevalence are not known with certainty because of the rarity of the disease and the existence of asymptomatic lesions. Our knowledge of the epidemiology of cerebral AVMs is largely based on data from autopsy series and population-based studies. Autopsy data suggests that the frequency of AVM detection is approximately 4.3%. In population-based studies, the reported incidence rates are approximately 1 per 100,000 patient years. The prevalence of cerebral AVMs is estimated at 18 in 100,000. Although these lesions are approximately 10 times less common than intracranial aneurysms, they account for 2% of all strokes and 38% of intracerebral hemorrhage in patients between the ages of 15 to 45 years. The pathogenesis of AVMs remains controversial. They are generally believed to be developmental lesions, although there is evidence that they may be acquired. It has been suggested that the retention of primordial arteriovenous connections from the fetal intracranial vasculature or failure of development of an intervening capillary network could result in the development of AVMs. Alternatively, it has been postulated that the primary abnormality in AVM pathogenesis lies within a disturbed venous drainage system. Venous hypertension or venous outflow restriction can result in local increases in angiogenic factors and may open pre-existing arteriovenous connections, resulting in arteriovenous shunts that can enlarge over time. Cerebral AVMs are commonly discovered in the third and fourth decade of life. However, they can present at any age. Studies have not revealed consistent gender predominance. AVMs can be located in a wide variety of anatomical locations, with the supratentorial compartment being the most common. The cerebellum is the most common location in the posterior fossa. On the other hand, the brainstem and ventricular locations are less common. AVMs are usually solitary, but multiple lesions have been reported in 1 to 9% of patients. The clinical presentation or discovery of AVMs can be classified into 5 basic categories. These include intracerebral hemorrhage, seizures, progressive neurological deficits, headaches, and incidental or asymptomatic lesions. Intracerebral hemorrhage remains the most common and most dangerous presentation. AVM rupture is responsible for approximately 50 to 70% of initial presentations. Accordingly, AVMs are responsible for 1/3 of hemorrhagic strokes in young adults, second only to a ruptured intracranial aneurysm. Intraparenchymal hemorrhage is the most common type of bleeding episode, followed by intraventricular and subarachnoid hemorrhages. Most patients experience their first hemorrhage when they are 20 to 40 years of age. Estimated mortality and permanent morbidity with each hemorrhage are 10 to 30% and 20 to 30% respectively. Seizures represent the second most common type of presentation in patients with supratentorial AVMs, occurring in almost 70% of patients. seizures without obvious hemorrhage are seen in 25 to 50% of cases. Approximately 18 to 35% of patients with an AVM are diagnosed during the evaluation for a seizure. The average age of onset is 25 years. Simple and complex partial seizures are the most common type recognized. Seizures have been found to occur more frequently in AVMs having one or more of the following features: large size, MCA distribution, cortical location of the nidus or arterial feeders, and the presence of venous varices. Approximately 3 to 10% of patients harboring a cerebral AVM present with a progressive neurological deficit in the absence of hemorrhage. The underlying pathophysiology is secondary to mass effect or due to ischemic stele. Mass effect may occur as a result of direct pressure of the AVM or cerebral edema in the surrounding parenchyma. Ischemic stele is thought to be the result of high flow, low resistance pathway created by the AVM. Cerebral blood flow from the adjacent tissue is thought to be stolen by the pathological malformation. This may lead to various symptoms depending on the anatomical location of ischemia. Larger AVMs and certain shunt characteristics are more likely to lead to symptomatic ischemic stele. Approximately 6 to 14% of patients with cerebral AVMs present with chronic headaches without hemorrhage. The pattern of headache is typically hemicranial, ipsilateral or contralateral to the malformation, and similar to migraines. However, the incidence of migraine headaches in patients with AVMs does not exceed that of the general population. Occipital AVMs may be more prone to headache presentation. When the headaches are migrainous in character in patients with occipital AVMs, they usually occur on the side of the AVM, and the visual phenomena, when they occur, are always on the contralateral visual field. This consistency in the lateralization of the migraine differentiates these patients with occipital AVMs from patients with classic migraine, in which the headaches typically change sides. Therefore, when a patient with migraines consistently reports the headaches and visual phenomena occur always on the same side, an imaging study is indicated to rule out an organic lesion such as an AVM. The pathophysiology of headaches is hypothesized to be caused by the recruitment of meningeal arteries and increased blood flow. As previously mentioned, most patients are diagnosed with AVMs after hemorrhage or seizure presentation. However, with increased use of non-invasive imaging, incidental discovery in patients evaluated for a variety of reasons is not uncommon. This proportion has increased to 10% in modern series, compared with a historical rate of less than 2%. A thorough understanding of the natural history of untreated AVMs is perhaps the most critical aspect of the management of patients with cerebral AVMs. This is because the entire rationale for treatment, regardless of the treatment modality, rests on the assumption that the treatment has a lower risk than the lifetime risk to the patient if the AVM is left untreated. This table summarizes the results of several classical natural history studies evaluating the risk of cerebral AVM rupture. Brown et al. Reported an annual risk of hemorrhage of 2.2%, whereas Crawford et al. Reported an annual risk of hemorrhage of 3.5%. In a study by Graff and colleagues, the annual risk of hemorrhage in patients with no history of previous bleed was 2 to 3%. Among the patients followed after their AVM ruptured, the risk of rebleeding increased to 6% in the first year, after which the average rebleeding rate fell to a constant level of 2% per year. A landmark study on the natural history of cerebral AVMs from the University of Helsinki was reported by Andra and colleagues in 1990. Among 262 patients with angiographically diagnosed cerebral AVMs, a total of 160 were untreated and comprised the natural history cohort. Clinical presentation included hemorrhage in 71% and seizures in 25%. The mean follow-up period was 23.7 years and was remarkably available in 98% of patients. During the follow-up period, 64 patients suffered at least one hemorrhage, ranging from 1 to 12 events. The annual risk of hemorrhage was 4%, and interestingly, did not differ for ruptured and unruptured AVMs, 4.3% and 3.9% per year, respectively. Although the study provided valuable information regarding the natural history of cerebral AVMs, it has several weaknesses. First, the study suffered a selection bias because 97 patients from the original 262 patients ultimately underwent intervention. Second, the diagnosis of hemorrhage was made before the availability of CT and was based on clinical suspicion, a positive lumbar puncture, or evidence of brain shift on radiograph. Finally, the annual hemorrhage rate was calculated by dividing all events by the years of follow-up. Patients with several hemorrhagic events were included, and thus the annual bleed rate may have been falsely exaggerated. In summary, these classical natural history studies demonstrated that the annual risk of hemorrhage is 2 to 4%. The rebleeding rate is approximately 6% during the first year following hemorrhage, after which the annual hemorrhage rate is similar to an AVM that has not bled. Some investigators have expressed concerns about the use of data from the classical natural history studies by Andra and colleague and Crawford and Associates to justify the treatment of patients harboring unruptured AVMs. They point out that most patients in these studies initially presented with hemorrhage, and that the reported annualized bleeding rates represent a blend of the natural history of both previously ruptured and unruptured AVMs. Therefore, the classical data likely overestimate the hemorrhage rate among unruptured AVMs and underestimate the rebleeding rate among ruptured AVMs. Subsequent studies have challenged the notion that the annual hemorrhage rate is similar for ruptured and unruptured AVMs. We would like to take a moment and review data gleaned from two large prospective AVM databases at the University of Helsinki and Columbia University. In 2008, Hernes Niemi and colleagues reported a follow-up study to the original Andra et al. Paper from the University of Helsinki. A total of 631 AVMs were evaluated from 1942 to 2005. Of those, 393 patients who rebled or were treated within 30 days of diagnosis were excluded. The remaining 238 patients were included in the group of untreated patients. Unlike the original study, rather than dividing all hemorrhagic events by years of follow-up, the authors performed a Kaplan-Meier analysis from presentation until first rebleeding episode. Furthermore, unlike the original study, the diagnosis of hemorrhage was based only on CT evidence. The average follow-up was 13.5 years, and the overall annual rupture rate was 2.4%. The rate was 3 times higher in the first 5 years, 4.6%, than in subsequent years, 1.6%, suggesting that a hemodynamic change may alter the risk of rupture. Several factors were associated with a greater risk of rupture on multivariate analysis. During the first 5 years, a previous hemorrhage and a deep location were risk factors. After 5 years, risk factors included previous hemorrhage, deep or infratentorial location, and large size. The hemorrhage risk varied from 12% for infratentorial AVMs in the first 5 years to 1% for supratentorial AVMs after 5 years. In this study, deep location and previous rupture increased the relative risk of rupture 4-fold. Large size was found to be a risk factor for hemorrhage only in multivariate analysis. Because small AVMs present with hemorrhage more frequently, it is likely that univariate analysis falsely raises the bleeding rate to equal that of large AVMs. However, in multivariate analysis, it is only when the influence of previous hemorrhage is removed and the two sizes are separated that large size shows up as an increased predictor of bleeding. Thus, small AVMs are more likely to present with hemorrhage because they do not present with symptoms secondary to mass effect or seizures. However, once they present, they are less likely to rebleed than large AVMs. Another study worth reviewing is that by Staff and Associates. Using the Columbia Prospective AVM database that was initiated in 1989, the authors reviewed the demographic, clinical, and morphological features of 622 patients diagnosed with an AVM. 45% of patients presented with a bleeding episode. The mean pre-treatment follow-up was 829 days. 70% were treated within 12 months. Independent risk factors for hemorrhage included older age, hemorrhagic presentation, deep location, and deep venous drainage. The overall annual rate of hemorrhage was 2.8% and was found to be lower for unruptured AVMs as compared to ruptured AVMs, 1.3% and 5.9% respectively. The authors subsequently evaluated the annual hemorrhage rates for 4 different subgroups based on the discovered independent risk factors. The table summarizes the results. AVMs without deep venous drainage and superficial location were found to have the lowest annual rate of hemorrhage, 0.9% in patients without a prior bleeding episode and 4.5% in patients who presented with a bleed. In AVMs with deep venous drainage but with a superficial location, the annual risk was 2.4% and 11.4% for unruptured and ruptured AVMs respectively. In AVMs without deep venous drainage but a deep location, The annual rupture risk was 3.1% and 14.8% for unruptured and ruptured AVMs respectively. Finally, AVMs with deep venous drainage and a deep anatomical location were found to have the highest annual risk of hemorrhage, 8% in patients without a prior bleeding episode and 34.3% in patients who presented with a bleed. From this table, it can be seen that the annual risk of hemorrhage can vary anywhere from 0.9% to 34.3% based on previously defined risk factors. Imaging. A CT scan is the primary neuroradiographic screening tool for patients presenting with acute neurological symptoms related to an unruptured or ruptured AVM. A non-contrast CT may demonstrate the presence of acute hemorrhage, hydrocephalus, calcifications, or areas of encephalomalacia related to a previous surgery or rupture. On the other hand, a contrast CT can provide information regarding the AVM location, nidus, feeding arteries, and draining veins, and is particularly valuable as a quick study in the setting of a life-threatening hemorrhage before surgical evacuation. An MRI is superior to CT in delineating the macroarchitectural details of the AVM, as well as defining its exact anatomical relation to the surrounding brain. An AVM typically appears as a tightly packed honeycomb of flow voids on T1 and T2 weighted images. Secondary changes in the adjacent brain tissue, such as mass effect, edema, and ischemic changes, can also be seen. On the other hand, magnetic resonance angiography currently cannot replace conventional cerebral angiography. Although MRI is sensitive in revealing subacute hemorrhage, in the setting of acute hemorrhage it is not very useful as the hematoma obscures all details of the AVM. We therefore recommend obtaining a formal cerebral angiogram in such cases if the clinical history and the imaging characteristics of the hematoma suggest the presence of an AVM. Cerebral digital subtraction angiography is still considered the gold standard to establish the diagnosis and to preoperatively assess a patient with an AVM. It can provide valuable information regarding size, location, configuration of the AVM nidus, as well as the pattern and location of feeding arteries and draining veins. Conventional angiography may also detect the presence of angioarchitectural features associated with an increased risk of hemorrhage, such as feeding artery or intranidal aneurysms, deep venous drainage, venous aneurysm or outflow compromise, perforating feeding vessels, and deep or periventricular location. External carotid injections should be performed in large convexity AVMs, particularly with a history of previous surgery, embolization, or hemorrhage, because these lesions may recruit external carotid artery supply. The timing of conventional angiography following a hemorrhage is also critical. Vessels that were not visualized on an early angiogram secondary to compression from a hemorrhage may appear on a subsequent study several weeks later. Therefore, it is important that an angiogram be performed close to the time of surgery because an AVM can change in size and configuration over time. Measuring the functionality of cortical structures adjacent to AVMs is critical when assessing the risk for intervention. Several techniques are available, including PET, functional MRI, and MEG. Information gleaned from these studies allows the surgeon to tailor treatment modalities. AVM grading. Several classification schemes have been proposed to grade cerebral AVMs. These grading systems attempt to encompass the various anatomic and physiological features of an AVM that influence treatment and are therefore able to estimate the risk associated with various therapeutic techniques. The Spessler-Martin grading system has become one of the most useful and widely accepted classification schemes for both communication of information regarding cerebral AVMs and prediction of the technical difficulty and risks associated with surgical resection. In this system, AVMs receive a grade from 1 to 5, which corresponds to a point scale depending on the size of the AVM, its proximity to eloquent neural tissue, and whether the AVM drains into the deep venous system. Size is scored by measuring the greatest diameter of the AVM nidus on either DSA, CT, or MRI. The AVM nidus is subsequently rated as small if it was less than 3 centimeters, medium if it was 3 to 6 centimeters, or large if it was greater than 6 centimeters. The size of the AVM serves as a surrogate for the number of feeding arteries, the amount of flow through the AVM, and the degree of hemodynamic effect on the adjacent brain. Eloquent neural tissue is defined as regions of the brain that harbor easily identifiable neurological function and can result in a disabling neurological deficit if injured. These regions include the sensory, motor, language, and visual cortex, the hypothalamus and thalamus, the internal capsule, brainstem, cerebral peduncles, and deep cerebellar nuclei. Venous drainage is scored as superficial if all the draining veins are components of the cortical venous system, and as deep if any or all the drainage is through the internal cerebral veins or the galenic system. In the posterior fossa, only the cerebellar cortical veins that drain directly into dural sinuses are considered superficial. The presence of deep venous drainage is simply a surrogate for deeper location, which confers more surgical risk. Deep venous drainage itself does not add to the surgical risk. It simply indicates that the AVM involves the ventricular wall or is located or extends to the deeper regions of the brain, which renders surgical resection more technically challenging because AVMs in these regions are difficult to access and are invariably supplied by deep perforating arteries, even if they are not visualized angiographically. Furthermore, involvement of the ventricular wall is associated with the presence of arterialized subependymal veins, which are fragile, resist coagulation, and tend to retract into the ventricles. The higher the AVM grade, the greater the difficulty and risk associated with surgical resection, and this has been validated in prospective series of AVM resections. Low-grade AVMs, grade 1 and 2, have low morbidity rates associated with the resection and are therefore typically treated surgically, whereas high-grade AVMs, grade 4 and 5, have high morbidity rates associated with the resection and are frequently managed conservatively. Grade 3 AVMs represent a heterogeneous group of lesions with variable surgical risk. In a surgical series of 74 patients with grade 3 AVMs, Dr. Lawton found that small grade 3 AVMs carried a surgical risk of 2.9%. Medium-sized grade 3 AVMs with deep venous drainage carried a surgical risk of 7.1%, and medium-sized grade 3 AVMs in eloquent location carried a surgical risk of 14.8%. Interestingly, there was no large grade 3 AVMs in this series because of either a selection bias or rarity of the lesion. Based on these results, Dr. Lawton suggested subdividing Spetzler-Martin grade 3 AVMs into grade 3 minus AVMs, which have a surgical risk similar to that of low-grade AVMs and can be safely treated with microsurgical resection, grade 3 plus AVMs, which have a surgical risk similar to that of high-grade AVMs and are best managed conservatively, and grade 3 AVMs, which have an intermediate surgical risk and require judicious selection for surgery. A similar modification was proposed by De Oliveira and colleagues. Grade 3 AVMs were subdivided into grade 3A if they were large and grade 3B if they were small but had deep venous drainage or were located in eloquent areas. The investigators generally recommended embolization followed by surgical resection for grade 3A AVMs and radiosurgery for grade 3B AVMs. Although many experienced surgeons have confirmed the validity of the Spetzler-Martin grading system in predicting surgical morbidity and mortality, the classification fails to directly address several important factors such as the pattern of arterial supply, the configuration of the nidus, the presence of feeding artery or intranidal aneurysms, the presence of direct arteriovenous fistulas, and stenosis or occlusion of the venous draining system. Furthermore, it does not take into consideration the surgeon's own personal experience. The management of patients with cerebral AVMs is based on a thorough understanding of the natural history and the risk for intervention. Decisions regarding the management of cerebral AVMs are complex. In the next section, we would like to discuss the various factors that should be taken into consideration in the decision-making process. It is useful to subdivide these factors into AVM-related factors, patient-related factors, and surgeon-related factors. AVM-related factors include AVM size, AVM location, pattern of venous drainage, and association with aneurysms. The influence of size on future hemorrhage has been controversial. Brown et al. Found that size was not a predictor of future hemorrhage, whereas Spetzler et al. Reported a significantly higher incidence of hemorrhagic presentation and documented higher intraoperative feeding artery pressures with small, less than 3 centimeter AVMs as compared to large, greater than 6 centimeter AVMs. On the other hand, as we discussed earlier, newer natural history studies have shown that large size is an independent factor for hemorrhage on multivariate analysis. Deep and infratentorial location has been shown to be associated with a higher risk of bleeding as compared to supratentorial AVMs. In addition, the morbidity rate associated with these hemorrhages is significant, with approximately 85% of patients suffering hemiparesis or hemiplegia. Given the worse natural history associated with these deep lesions, treatment may be considered as the risk of intervention may outweigh the risk of observation. Deep venous drainage has also been thought to be an important risk factor for AVM hemorrhage. Similarly, AVMs with a single draining vein or with impairment of venous drainage caused by stenosis or kinking may have a higher risk of bleeding. This can be explained by impaired venous outflow from the AVM nidus resulting in hemodynamic overload and eventual rupture. The association of aneurysms and AVMs is not an infrequent occurrence. Incidence rates range from 2.7 to 58%, with an overall average of approximately 10% in most series. Several classifications exist. However, a simple classification includes intranidal aneurysms, which can be either arterial or venous, flow-related aneurysms in the arterial pedicles feeding the AVM, and unrelated aneurysms on arteries not directly feeding the AVM. AVMs associated with intranidal and flow-related aneurysms may have a higher hemorrhage rate. On the other hand, the natural history of unrelated remote aneurysms, in our opinion, is not different from that of a similar unruptured aneurysm not associated with an AVM. The management of an AVM associated with an intracranial aneurysm depends on whether the patient presents with a hemorrhage. The following flowchart reviews the management of aneurysms associated with AVMs in the setting of hemorrhage. In the setting of an intracranial hemorrhage, the clinician must first determine the source of bleeding based on the pattern of hemorrhage on CT or aneurysm morphology on angiography. Subarachnoid hemorrhage is usually suggestive of aneurysmal rupture, whereas an intraparenchymal clot is generally due to bleeding from the AVM. However, it is frequently difficult to determine the source of hemorrhage, particularly with intranidal aneurysms. If the hemorrhage has been determined to arise from the aneurysm, subsequent management will depend on the proximity and accessibility of the aneurysm to the AVM. If the aneurysm is not in proximity to the AVM, remote, or proximal flow-related aneurysm, the treatment should be first directed at securing the aneurysm by surgical clipping or endovascular coiling, followed by definitive treatment of the AVM if deemed suitable. If the aneurysm is in proximity of the AVM, distal flow-related or intranidal aneurysms, the clinician must then determine whether the AVM can be cured by surgical resection or embolization. If the AVM is curable, then simultaneous treatment of both the aneurysm and the AVM should be performed. Otherwise, the aneurysm should be secured first, followed by definitive treatment of the AVM, either by surgery, endovascular embolization, or radiosurgery. If the source of hemorrhage has been determined to arise from the AVM, patients should be managed conservatively, with blood pressure control and measures to reduce brain edema, provided that the parenchymal clot does not require urgent surgical evacuation. A repeat angiogram should be performed 4 to 6 weeks after the blood has resolved. Subsequent management of the AVM and aneurysm should proceed as in an elective case, and treatment offered if deemed suitable, which will be discussed later in the next flowchart. If the clinician cannot pinpoint the source of hemorrhage, we recommend treatment of both lesions when possible. Otherwise, treatment should be directed towards the aneurysm first, because the morbidity and mortality associated with aneurysmal rupture is significantly higher than with an AVM. Furthermore, the risk of repeated hemorrhage from an AVM is significantly lower than that for aneurysms, and we have to presume in these cases that either lesion could have been the source of hemorrhage. The following flowchart reviews the management of an AVM associated with an intracranial aneurysm that has not presented with hemorrhage. The initial management depends on the type of aneurysm. Treatment decisions for remote, unrelated aneurysms are not different from those made for similar aneurysms not associated with an AVM. The management of associated intranidal aneurysms is more challenging because the natural history is not clearly defined. Surgical resection of the AVM or complete endovascular embolization should be undertaken if possible. Otherwise, a partial AVM embolization, including occlusion of the intranidal aneurysm, should be contemplated if it can be performed safely. The management of flow-related aneurysms that are discovered incidentally in association with an AVM is controversial. 3 possible strategies exist, including treatment of the AVM first, treatment of the aneurysm first, or simultaneous treatment of both lesions. Authors who advocate initial targeting of the AVM base their treatment rationale on numerous reports of spontaneous regression of flow-related aneurysms following successful obliteration of the AVM. On the other hand, authors who advocate initial treatment of the aneurysm base their treatment rationale on reports of aneurysm rupture during the course of AVM therapy. In such instances, it's believed that the elimination of the AVM can cause an increase in intraluminal pressure, which may theoretically result in aneurysm rupture. Our approach to the management of incidental flow-related and intranidal aneurysms associated with AVMs depends on whether the AVM can be cured surgically or by endovascular embolization. If the AVM cannot be cured by surgical or endovascular means, a decision should be made as to whether the lesion is amenable to stereotactic radiosurgery. If the AVM can be treated by radiosurgery, we first recommend securing the aneurysm because there has been reports of aneurysm rupture during the follow-up period after AVM treatment with stereotactic radiosurgery. If the AVM is too large for radiosurgery, the decision to treat the aneurysm is then based on whether it is amenable to surgical clipping or endovascular coiling. If the AVM can be cured, then the clinician must determine the accessibility and proximity of the aneurysm to the AVM. If the aneurysm is accessible and in close proximity to the AVM, we recommend treatment of both lesions simultaneously. Otherwise, we recommend treatment of the aneurysm first, followed by definitive treatment of the AVM. There are several patient-related factors that must be considered in the decision-making process. The patient's age is important in determining the cumulative risk for AVM rupture during the remainder of the patient's life expectancy. Therefore, one may justify a more aggressive approach for surgical treatment in younger patients because their cumulative risk for hemorrhage is so high. In addition, a neurological deficit is generally better tolerated if it occurs at a young age. The general health of the patient is important because severe comorbid conditions may preclude surgery as a reasonable treatment option. The clinical presentation and neurological condition of a patient will often dictate the timing of surgery. For example, the patient may need emergent evacuation of a hematoma caused by a ruptured AVM, or it may be best to wait until the patient is improved to a neurological plateau when the AVM resection can be performed electively. Patients with AVMs who present with major hemorrhage, progressive neurological deterioration, uncontrolled epilepsy, or intractable headaches should be considered for surgical resection. Finally, the occupation and lifestyle of a patient are important considerations when considering treatment of an AVM in a critical area of the brain. For example, the high probability of a visual field deficit following resection of an occipital AVM may not be acceptable by a pilot who is dependent on perfect vision. A surgeon's personal experience, as well as the experience of his or her institution with AVM management, is an important factor to be considered. The surgeon should be familiar with the literature as well as his or her own personal experience and should be able to explain to the patient all treatment options with their associated risks and benefits. The main goal of treatment of a cerebral AVM is prevention of future hemorrhage and possible neurological deterioration. Currently, the treatment options for AVMs include microsurgical resection alone, preoperative endovascular embolization followed by microsurgical resection, stereotactic radiosurgery alone, pre-procedural endovascular embolization followed by radiosurgical treatment, endovascular embolization only, and observation only. Microsurgical resection. AVM surgery is generally an elective procedure. In cases of ruptured AVMs that lead to intracranial hemorrhage and no significant neurological deficits, we recommend operating in a delayed fashion, approximately 4 to 6 weeks after the initial hemorrhage. During this time period, the risk for early rebleeding is relatively low, yet the delay allows time for the hematoma to liquefy and associated surrounding edema to resolve and the dysautoregulated brain tissue to recover. On the other hand, in the setting of life-threatening hemorrhage necessitating urgent surgery, we generally recommend only gentle evacuation of the clot without disturbing the AVM. However, in cases of small, superficial AVMs, an attempt can be made at removing the AVM with the clot during the same setting. It is important to recognize that significant neurological deficits following AVM rupture are not necessarily permanent, and that frequently the deficit observed is a result of the hematoma exerting pressure on critical brain structures rather than actual destruction of functional neural tissue. We therefore recommend delaying surgery to allow such potential recovery to occur. Finally, as stated earlier, we prefer to repeat the cerebral angiogram near the time of surgery to make sure that the AVM configuration has not changed since the time of the hemorrhage. In the next section, we will discuss the general surgical technique for resection of AVMs as demonstrated through a case illustration. Details regarding the surgical technique for AVMs in specific regions of the brain are too extensive to discuss in this presentation. We encourage the reader to refer to the text of the chapter for more details. This is a surgical video demonstrating the resection of a left frontal arteriovenous malformation. The patient is a 28-year-old male who's found to have an incidental left frontal AVM during workup following a motor vehicle accident. Preoperative MRI demonstrated the typical honeycomb appearance of the arteriovenous malformation located within the left frontal lobe, well anterior to the motor cortex and superior to Broca's area. Preoperative digital subtraction angiogram demonstrated that the AVM was fed primarily by several large branches from the anterior cerebral artery, as well as numerous smaller branches from the middle cerebral artery. The AVM nidus measured approximately 3.5 centimeters and drained primarily via a large cortical vein into the superior sagittal sinus. Of note, there was also an incidental 2 millimeter superior hypophyseal artery aneurysm. Preoperative embolization was not performed in this case in order to reduce the overall risk of intervention. It was felt that preoperative embolization would not significantly reduce the surgical morbidity, yet would still expose the patient to the risk of embolization. The procedure was performed in a hybrid operating room that was fully equipped with an operative microscope, a neuronavigation system, intraoperative neurophysiological monitoring, and the capability to perform a post-AVM resection intraoperative angiogram. The patient was positioned supine with the head turned approximately 10 degrees to the right and fixed in a 3-pin Mayfield head clamp. A partial bicoronal scalp incision was made, followed by a left frontal craniotomy extending across the midline to expose the superior sagittal sinus. The dura is carefully opened to avoid injury to adjacent superficial draining veins. For cortical AVMs, we prefer a large craniotomy with a margin of a few centimeters around the lesion. The main advantage of a large exposure is the ability to easily identify the cortical vascular anatomy for comparison with the cerebral angiogram. Occasionally, feeding arteries are seen on the cortical surface at some distance from the AVM before their descent into a sulcus to reach the malformation, and would therefore not be apparent through a smaller craniotomy. Similarly, the change in color of an arterialized draining vein to blue, an indicator that the arterial supply to the AVM has been interrupted, may be only seen several centimeters away from the lesion as the veins receive normal cortical drainage. Finally, it is more difficult to control bleeding from the surrounding parenchyma through a smaller craniotomy. In this surgical view of the left frontal lobe, the anterior and posterior aspect of the exposure is located at the top and bottom of the screen respectively. The MCA feeders located laterally and the superior sagittal sinus located medially can be seen at the left and right side of the screen respectively. Several arterialized veins can be seen draining into the superior sagittal sinus. Endocyanine green angiography may be performed at the start of the case to help differentiate arterial supply from venous drainage. Excision of an AVM generally proceeds through several well-defined stages. The first step in this case was to systematically identify, coagulate, and section the middle cerebral artery feeding vessels. The acronoidal membrane is opened over the sulci at the periphery of the AVM. There are several pearls worth mentioning regarding the technique of feeding artery disconnection. It should be noted that it is difficult to coagulate high-flow AVM feeders than a normal artery of the same diameter. This can be clearly demonstrated here where coagulation of an arterial feeder resulted in rupture of the vessel, which was easily controlled with an AVM clip. Interruption of flow through a large feeding artery with a temporary AVM or wet clip can facilitate coagulation of the artery. Another point worth mentioning is the use of irrigating bipolar forceps, which are extremely useful during AVM surgery. Feeding arteries are intermittently coagulated for 1 to 2 seconds under constant irrigation while avoiding complete closure of the forceps to prevent adherence of the cauterized vessel to the bipolar tips. Similarly, the bipolar tips should always be kept clean to minimize sticking. When sectioning a coagulated feeding artery, it is important to partially divide the artery first to ensure that it has been fully coagulated. Finally, it is important to section the arterial feeders closer to the nidus. This is particularly useful when dealing with deep feeders, so that in the event that the feeding artery continues to bleed after it has been sectioned, there's less of a chance that it retracts into the brain parenchyma. Once all superficial feeders have been sacrificed, a circumferential cortical incision is made immediately adjacent to the AVM. At this stage of the procedure, we begin working on the posterior border of the AVM in a similar manner by opening the sulci and then identifying and disconnecting the arterial feeders. We then open the arachnoidal membrane anterior to a posterior cortical vein. A large superficial feeding artery is identified and subsequently coagulated and sectioned. We then continue opening the arachnoid membrane towards the interhemispheric fissure. The sulcus is opened and more superficial feeding arteries identified and disconnected. The corticectomy is deepened, and as you can see, we're working along the loops of the AVM nidus. A large ACA feeder is identified and occluded with an aneurysm clip. The artery was then coagulated and sectioned. The corticectomy was deepened to the depth of the sulcus, circumferentially around the AVM. Additional superficial feeding arteries were identified and sacrificed. We're once again working along the lateral margin of the AVM, but advancing our dissection more anteriorly. The sulci are opened and all the superficial MCA feeders identified and subsequently coagulated and sectioned. A patty is placed to mark the depth of dissection, and we continue to work along the AVM loops. A handheld retractor can be very useful to gently elevate the portion of the AVM nidus that has been dissected to facilitate further dissection along the undersurface of the AVM. The corticectomy has been extended medially towards the inner hemispheric fissure, and we can now see the falx coming into view. A large ACA feeder is identified and occluded with an aneurysm clip to facilitate coagulation and subsequent sectioning. The handheld retractor is repositioned and the AVM is gently elevated, and we continue to work adjacent to the loops of the AVM nidus. Now we're working along the anterior border of the AVM. What's interesting here is that you can see the arterialized draining vein changing color. During systole, the vein is arterialized, but during diastole, the vein becomes blue. This is an indicator that we're making good progress with our resection and that many of the feeders to the AVM have been disconnected. The AVM nidus is gently elevated, and we continue the dissection adjacent to the AVM loops along the undersurface and towards the inner hemispheric fissure. And now we can see another large ACA feeder coming into view. We continue our dissection under the AVM nidus. And once again, within the inner hemispheric fissure, we can see another large ACA feeder, which is occluded with an aneurysm clip. The retractor is repositioned, and then we continue our circumferential dissection, and now are working along the anterior border of the AVM. Now we're working along the undersurface anteriorly. Here's another large ACA feeder, which is occluded with a clip and subsequently coagulated and sectioned. We continue our dissection underneath the anterior portion of the AVM towards the inner hemispheric fissure. Another large ACA feeder is clipped and subsequently sectioned. Now we're disconnecting the final attachments of the anterior portion of the AVM nidus. The anterior-most arterialized draining vein is coagulated and sectioned. There's a small attachment of the AVM posteriorly that still needs to be disconnected. The nidus has been completely dissected from the surrounding brain tissue and remains attached only by the main draining vein to the superior sagittal sinus. The vein has now become darker in color, and we proceed with coagulating and sectioning the vessel. The AVM nidus is removed and the resection cavity is inspected for residual AVM nidus. As you can see, there is a bleeding vessel from the brain. It is very important to resist the temptation of packing the bleeding, as it may result in serious intraparenchymal hemorrhage. The surgeon must be diligent in finding and occluding the offending vessel, either with bipolar coagulation or, as in this case, with a small AVM clip. Once hemostasis has been achieved, the patient's mean arterial pressure is raised approximately 15 to 20 millimeter of mercury above baseline and maintained for approximately 10 minutes. Any bleeding during this period is highly suspicious for a residual AVM and should be inspected thoroughly. In this case, we found a small residual nidus at the interior margin of the resection cavity, and it was easily removed. If no bleeding occurs after a period of temporary blood pressure elevation, the surgical cavity is then lined with a single layer of Surgicel, and the patient's blood pressure is kept at or slightly below normal and maintained for a period of 24 hours. An intraoperative angiogram was then performed and confirmed complete AVM resection. The patient did well following surgery and had an uneventful postoperative course. Microsurgical complications. Complications related to microsurgical resection of AVMs can occur either during the time of excision or following surgery. Intraoperative hemorrhage and intraparenchymal injury are two common complications encountered during AVM resection. Bleeding during surgery is either directly from the AVM during nidal dissection or secondarily from premature occlusion of major draining veins. Intraparenchymal injury can occur as a result of a wide circumferential resection of cortical tissue, transection of arterial feeders far from the nidus, excessive brain retraction, and bridging vein injury. Several complications can also be encountered following surgery. The most immediate and morbid postoperative complication is hemorrhage. This is the result of either inadequate hemostasis or residual nidus. The risk of inadvertent residual nidus can almost be eliminated with the use of intraoperative angiography. 15% of patients without a history of seizures develop first-time seizures postoperatively. On the other hand, approximately 12% of patients presenting with seizures experience worsening of their seizures. Because of this risk, some have recommended a minimum of 6 months of anti-epileptic treatment following the resection of supratentorial AVMs. Normal perfusion pressure breakthrough are hemodynamic changes following AVM resection that can lead to cerebral edema, hemorrhage, or both. It is more commonly seen in AVMs that have large caliber, high flow feeding arteries that divert flow from surrounding parenchyma, resulting in an arterial steal phenomenon. Normal perfusion pressure breakthrough can be avoided by selectively embolizing AVMs with these high-risk characteristics. Following AVM resection, angiographic feeding artery stasis is a common finding that can last up to 1 month. Thrombosis of these arteries rarely occurs and has been reported to occur in approximately 6.6% of cases and is more commonly seen in elderly patients. Retrograde venous thrombosis can also occur following surgery as a manifestation of venous stasis in large draining veins. Postoperative vasospasm is an extremely rare complication and has been described to occur in AVMs that require extensive dissection of en-passage feeding vessels. Radiosurgery. Although a more detailed discussion can be found in separate chapters in this book, we would like to briefly discuss some issues related to radiosurgical management of cerebral AVMs. The aim of radiosurgery is gradual obliteration of the AVM by progressive intimal hyperplasia and progressive nidal thrombosis. Stereotactic radiosurgery is ideal for small, less than 3 centimeter AVMs located in eloquent or deep-seated areas of the brain where the morbidity of surgical excision would be considered unacceptable. It is also a good treatment choice for patients whose age or comorbidities makes the risk of general anesthesia unacceptable. AVM size has been shown to be an important predictor of successful obliteration. Increasing AVM size reciprocally affects obliteration rates, and repeated radiosurgery for incompletely obliterated AVMs carries a worse rate for subsequent obliteration. For more information regarding the obliteration rates for cerebral AVMs of various size, please refer to the table included in this chapter. The two main disadvantages of radiosurgery are the latent period until complete obliteration and the lack of certainty of obliteration. During these periods of delay, which may range from 1 year to several years, the patient remains at risk for hemorrhage, and the risk is almost the same as if no treatment had occurred, at least during the early follow-up. AVMs may reappear after having been totally occluded after radiosurgery, particularly in children. Factors associated with radiosurgery failure include changes in nidus morphology after radiosurgery because of resolution of hematoma, recanalization of a previously embolized portion of the AVM, technical errors in treatment planning, large nidus size greater than 10 centimeter cube, and increasing Spetzler-Martin grade. There is a small but significant risk of neurological injury from radiation damage, which occurs in approximately 3 to 10% of cases, depending on the AVM location. AVMs in or adjacent to functional brain tissue have a higher risk of radiation injury. Radiation-induced changes typically manifest 6 to 18 months after radiosurgery as perinatal T2 signal changes on follow-up neuroimaging. Although most radiation-induced changes are asymptomatic, a subset of patients with radiographically evident radiation-induced changes develop neurological symptoms such as headache, seizure, and focal neurological deficit. In addition to radiation damage, rare cases of secondary tumors from radiosurgery have also been reported. Other complications include death, cranial nerve injury, new or worsening seizures, increased risk of rehemorrhage following radiosurgery in large AVMs and older patients, and occlusive hyperemia. Endovascular therapy. Although a more detailed discussion can be found in separate chapters in this book, we would like to briefly discuss some issues related to embolization of cerebral AVMs. Endovascular therapy has become an important therapeutic tool in the management of cerebral AVMs. Currently, endovascular therapy is used in several ways, including as adjuvant embolization before definitive surgical resection or prior to radiation therapy, as palliative therapy targeted towards angiographic high-risk features, such as feeding artery or intranidal aneurysms, or to decrease flow in patients presenting with progressive neurological deficits, and finally, as curative or complete AVM occlusion. In the following section, we will discuss each of these indications. Preoperative embolization. Embolization prior to definitive surgical resection is the main indication for endovascular therapy. Because of the morbidity associated with embolization, it should be targeted with the goal of increasing the safety of surgical resection. Preoperative occlusion of arterial feeders that are inaccessible during early surgical exposure can be very helpful. For example, in this case of a right parieto occipital AVM, the arterial supply was from both the MCA and PCA branches. Embolization was targeted towards occlusion of the PCA feeders, as access to these arteries would occur during the latter stages of surgical resection. On the other hand, the MCA feeders could be easily interrupted during the early stages of resection, and therefore it was felt that embolization of these branches would not be greatly beneficial. Another example of targeted embolization is the preoperative embolization of perforator supply to an AVM, which can greatly increase the safety of surgical resection. For example, in this case of a thalamic AVM, the primary feeder was a posterior thalamoperforating artery. Preoperative embolization of the artery was performed and facilitated safe resection via a subtemporal approach. On the other hand, embolization of superficial feeders that can be easily controlled at surgery was not necessary. Another indication for preoperative embolization is the occlusion of ruptured proximal feeding artery aneurysms before resection or radiosurgery. For example, in this case of a ruptured medial occipital AVM, preoperative embolization of 2 proximal feeding artery aneurysms was performed prior to definitive surgical resection. Other indications include staged embolization of large high-flow AVMs with the goal of gradual reduction of arteriovenous shunting to restore normal cerebral vascular reactivity and potentially minimizing the risk of post-operative normal pressure perfusion breakthrough. Occasionally, embolization may be performed for AVMs located within or adjacent to eloquent regions of the brain in an attempt to significantly reduce the blood flow within the lesion and make them amenable to surgical excision. Finally, AVMs that have acquired dural or transosseous feeders can significantly bleed while elevating a craniotomy flap. Preoperative embolization of these arteries can greatly increase the safety of surgery. As a final note, preoperative embolization should not be performed indiscriminately for the purpose of reduction of blood flow to make the surgery faster or easier for the surgeon. As a general rule, the cumulative risk of embolization plus surgical excision should be less than the risk of surgical excision alone. Indications for pre-radiosurgical embolization. Embolization has been frequently used to reduce the size of large, inoperable AVMs to make them amenable to radiosurgery. As previously discussed, pre-radiosurgical embolization can also be used for occlusion of ruptured proximal feeding artery aneurysms. It should be noted that there is no definitive evidence that pre-radiosurgical embolization reduces the risk of hemorrhage during the time period until complete AVM obliteration occurs, and therefore we generally do not recommend the use of embolization for this reason. Delayed recanalization and reappearance of the portion of the AVM nidus not included in the radiation field has been known to occur. In fact, previous embolization has been reported as a negative predictor of successful AVM obliteration following radiosurgery. Failure of radiosurgery is particularly common following particle embolization, with reported cases of recanalization ranging from 15 to 20%. Although recanalization can also occur with liquid embolics, it is less common and typically seen in cases in which embolization results in pedicular occlusion with minimal to no penetration of the nidus. Palliative embolization. Palliative or partial embolization of AVMs that are inoperable or not suitable for radiosurgery may be considered for several reasons. In patients presenting with hemorrhage, it may be used to target high-risk angiographic features such as feeding artery or intranidal aneurysms or direct fistulas. Embolization may also be used to reduce flow through large AVMs in patients with intractable headaches or progressive neurological deficits related to arterial steel or venous hypertension. Finally, partial embolization may be considered in patients with a history of multiple hemorrhages from an inoperable AVM, despite the fact that impact of such embolization on the natural history is not clear, as we will discuss in the next slide. The issue of whether palliative or partial embolization alters the natural history is unclear. Most studies have suggested that such embolization does not improve clinical outcomes compared with conservative therapy. For more details regarding such studies, please refer to the main chapter. Curative embolization. The reported rates of complete AVM obliteration following embolization vary according to the AVM grade, the embolic material used, the available technology, and the expertise of the treating center. For more information regarding the obliteration and morbidity and mortality rates for cerebral AVM embolization, please refer to the table included in this chapter. Overall complete obliteration rates have been reported to be between 5 to 30% in most series. The obliteration rates are significantly higher in cases selected with an intention for cure, particularly in grade 1 and 2 AVMs, with reported occlusion rates of greater than 98%. Conclusion. Cerebral AVMs are heterogeneous lesions, and decisions regarding management require a thorough understanding of the natural history and the risks of intervention. The management should be highly individualized for each patient according to the AVM characteristics and the expertise of the treating institution. Grade 1 and 2 AVMs should be offered surgical excision provided that the patients are relatively young and healthy. Radiosurgery may be a reasonable alternative in elderly patients with significant surgical comorbidities. Decisions regarding grade 3 AVMs are not straightforward, although many can be surgically resected with acceptable morbidity. The vast majority of grade 4 and grade 5 AVMs should be treated conservatively, as surgical resection is associated with serious morbidity and the chance of complete obliteration with multimodal therapy is low. Preoperative embolization may be used to occlude arterial feeders that would be inaccessible during early surgical exposure, or perforator supply to increase the safety of surgical resection. Preoperative embolization is also valuable in large, high-flow AVMs to reduce the risk of operative and postoperative complications. It may also be used in some AVMs in or near eloquent areas of the brain to allow safe resection. However, because of the risk associated with embolization, it should not be used solely for the purpose of making surgical excision faster or easier. Palliative embolization may be considered in selected cases to target high-risk angiographic features or reduce AVM flow in patients with intractable headaches or progressive neurological deficits related to arterial steel or venous hypertension. Curative embolization, in our opinion, should be reserved for selected cases and performed only at institutions with significant experience in the technique. Radiosurgery remains an excellent treatment option for small, deep lesions. Thank you.